Tokyo Live Endoscopy 1.
Welcome, everybody. It's been a real pleasure to be part of this fantastic meeting at Tokyo Live. I have the great honor of introducing our first speaker. Professor Kudo needs no introduction to this audience. I had the pleasure of working with him in 2010 at Show University. He is the professor of the Digestive Diseases Center at Show University, Northern Yokohama Hospital. He has an extended career in the endoscopic diagnosis of colorectal polyps and was the person that introduced a PIT pattern to the world. And since then, we have really been using his classification to develop the endoscopic diagnosis. It's a great honor to welcome him to this particular session, and he will be discussing today the endoscopic diagnosis using PIT pattern and also ultramagnification using endocytoscopy. So Professor Kudo, great honor to have you here, and thank you very much for your time.
Thank you for your introduction. I'll start. I'd like to thank you for opportunity to give this presentation today. This photograph is the most famous protrude region in Japan, Mount Fuji. Today, PIT pattern to endocytoscopy diagnosis. This is a 2C region, display method. You can see them very clearly. And the depressed type tumor become invasive cancer even in small size. Don't overlook such small regions. Here, display method, you can see the very clearly the depressed area. Quite a difference. And the depressed cancer, this is a faint redness. And display method, you can see the clearly depressed area. And the magnification, and you can see the PIT pattern diagnosis, depressed area. Small roundish PIT pattern than normal PIT. Here, sprint. PIT pattern, colorectal tumor and PIT pattern. I published 1994, Journal Clinical Pathology. PIT pattern is colorectal neoplasia magnified view, endoscopy 2001. And from type 1 to type 5. Type 3 is small tubal or roundish PIT is a de novo PIT pattern. And de novo PIT pattern, depressed region, less than 5 millimeter in diameter. 9.7% is invasive cancer. But the flat or protruded region is 7,000, also protruded region 7,000, 0%. And less than 10 millimeter. Invasive rate 59.1%, very high. Flat region 0.9, protruded 0.9. And less than 15, 81, very high. 7.1%. So totally quite a difference. This is the first case, 1985, I found in descending colon trans. This one. And here. Depressed region. First. This second case, 3 months after the first case, 1985, here, faint redness. Yeah. World Congress of Gastroenterology. I present first in the world reported depressed type. And this is 2 cases. a day, 96, 11:34 minutes. I've found out one case, depressed region. And after 1 hour later, next case, I found also depressed region, same day. Invasive cancer. And this is invasive cancer also. But this patient, liver metastasis, 3 years later. Depressed type colorectal, very important region, and referred to Kudo disease 35 years ago. It was not well recognized even in Japan at that time. Therefore, it was rare to be found outside our institution. Now it's an established entity in Japan. More regions were found throughout the world. And this is carcinoma of the colon and WHO book. And this one depressed region and flat region. Invasive cancer. And this is very big adenoma, 47 millimeter. This tooth region, only 9 millimeter diameter. FAP, familial adenomatous polyposis, is a very famous genetic region. Depressed type chronic region and de novo cancer in familial adenomatous polyposis chronic viewpoint published. This is a region, depressed region in tooth region in FAP. And another case, depressed region in FAP. Also, many polyposis and depressed region. De novo cancer and adenoma. How to grow? Esophagus, mainly depressed regions. And stomach also, de novo pathway to C region. And small intestine, no cancer, not so many cancer. But the colorectal cancer, it must be de novo pathway to C region. I believe it. And I found that many depressed region, 1996. Early book review. Based on these observations, Dr. Kudo content, we can decide on the spot to ignore biopsy or reject colony. President of American Society of Gastroenterology, Charles rightly described. Growing process of the polyp. Usually, many doctors believe adenoma, carcinoma sequence. But the cancer, adenoma carcinoma was very famous Professor Fogelstein, APC, KRAS point emitter P53 DCC. But the de novo cancer is quite different evaluation of colorectal cancer. Endocytoscopy. Endoscopic diagnosis. Pit pattern. Endocytoscope 500 magnification can detect nucleus and cell. This is very exciting case. Look like small polyp, but this is a depressed region. Dye spray method, you can see clearly depressed area. Roundish whitish area is a normal mucosa, but the depressed area is invasive cancer. Column display is clearly 5 millimeter depressed invasive cancer with endoscopy and super magnified endoscope. You can see the nucleus, many big nucleus, endocytoscope. Diagnose invasive cancer 98%. Many places you can see the invasive cancer, big nucleus, invasive cancer 99%. Well differentiated adenocarcinoma, this case, 2050 micrometer lymphovascular lesion plus budding plus nodal metastasis negative. Cancer invasion submucosa, normal mucosa surrounding elevated lesion. And this is my classification, super magnified endoscope, non-neoplasia to destroyed gland invasive cancer, mucosal cancer, adenoma, slit-like lesion, and hyperplastic polyp. AI. What is AI? An attempt to artify to realize intelligence similar human computer. And the brain eye, published in Nature. Published in Nature 2021, May 6. In the future, it will be possible to accurately discover depressed region. Being submit, detecting depressed colorectal with the use of the artificial intelligence assist, real-time use with analysis of internal medicine, also cost-effective, and artificial analysis of artificial intelligence assisted detection colonoscopy improves adenoma detection rate, large-scale plasma gastrectomy study. AI breaks the limit to colonoscopy detection, increase tumor detection rate, pathological, and brain eye, gastroenterology, 89%. AI breaks the limited colonoscopy, pathological diagnosis, properly diagnosed tumor, and the brain. We name it in the brain. Adenoma 93%, adenoma 98%. Discover depressed cancer with AI. I will show you the video. The molecular pathway of colorectal cancer, adenocarcinoma sequence, polypoid region to the, but the de novo pathway is quite different. Fast depressed and small size adenocarcinoma sequence slow growing. We are trying to clarify molecular characteristic. De novo pathway, adenocarcinoma sequence. TP53, EPC, KRAS. We are trying to clarify molecular characteristics, depressed characteristics. KRAS mutation is rare in depressed cancer. Copy number gain would contribute to the cancerous of the depressed cancer. Angiogenesis, EMT, and inflammatory response expression were in the depressed cancer. Molecular characteristics depressed cancer is gradually qualified. I visited many countries, over 50 countries and 350 times visited so far. Karolinska Institute, Alfred Nobel in Sweden. And I went to sometime and Karolinska Institute when I was young, and Cleveland Clinic in America many times. First early breast cancer EMR in the US 1991, breast near here. First case of the USA breast region. Brazil, São Paulo University, and Cochin, Paris University, Professor Stanisław Kresta. This is a poster of my breast region. Mayo Clinic Hospital, I visited. And the King's College Hospital in London, and London King's Live. Every year I attended. Characteristic of the breast tumor may be overlooked over the world, embedded into some mucosal layer within small size, tend to metastasize. Progress of endoscopic diagnosis. Pit pattern diagnosis standardized the endoscopic diagnosis. Endocytoscope has the potential to replace pathological diagnosis. AI will dramatically change the quality of the endoscopic diagnosis. Thank you for your attention.
Thank you very much, Professor Kudo, for an outstanding lecture. In every time I listen to you, I always learn something new regarding endoscopic diagnosis, and it's fascinating regarding the development of the technology in terms of magnification to ultra magnification. I think this would be a real treat for the audience that have been listening today. So thank you very much. It's been an outstanding lecture. It's a great honor now for me to introduce our next speaker, Yuichi Mori. Yuichi has had an outstanding career since he first qualified at Showa University. He's been based at Showa University for many years, and since then has moved to the University of Oslo. He is a real expert in endoscopic diagnosis, not only in magnification and endocytoscopy, but of course in endobrain. And many of you have heard his outstanding contribution to this field over the years. So I'm very much looking forward to his lecture. So thank you very much, Yuichi, for joining us.
Thanks, Sami. Actually, I have already submitted my video presentation, so it will be played back, I guess. Hello, everyone. Thank you very much for your kind introduction, Ami and Dr. Kudo. It is my great pleasure to be able to talk about AI on colonoscopy today. So today, I'm going to be focused on detection and characterization for colorectal endoscopy. This is my COI, and as you can see, I think the field on AI in colonoscopy or GI endoscopy is almost exploding in terms of the number of publications and also in terms of the variety of the research topics. And as you can see, the number of publications becomes almost 10 times more than the previous years. In 2020, we've got over 200 publications, while in 2016, we've got just 10 or less publications. And if you look at the variety of the publication or research field, it is also amazing. Because AI in colonoscopy or endoscopy includes the area on Barrett's esophagus, esophageal cancer or gastric cancer detection. And also we have some researches focused on the classification of the inflammation status of ulcerative colitis. And also the AI technology is already established in the field of capsule endoscopy, and some ambitious researchers are now working on the topics such as the ERCP and the US. And among these subjects, I would say the colonoscopy is leading the role in terms of the number of publication and also the quality of publication. And also, we can get a lot of the items on the market in the field of endoscopy or lower GI endoscopy. And if you look at the categories of the research or the roles of AI, there are roughly 3 major roles. One is a computer-aided detection, which will help us to detect the polyps or abnormality, while the remaining 2 include the computer-aided diagnosis and computer-aided quality assurance. Computer-aided diagnosis is really helpful for us to identify the polyp characteristics, including the histopathological pattern. And the computer-aided quality assurance is an emerging research field, which will give us information on withdrawal speed or the rate of the blind spots during the withdrawal, which definitely increases the quality of endoscopy in a real-time fashion. And if you look at the market, it is amazing because, as you can see, the more than 10 AI tools have already secured the regulatory approval in Europe, Japan, and the United States. And amazingly, in the field of CDE, more than 10 devices have already been secured in terms of regulatory approval. And also, if you look at the name of the manufacturers, main endoscopy corporations such as the Olympus, Fujifilm, or Pentax have already released their main devices as the CDE tool. So I would say I think the use of CDE is going to be the standard function of the endoscopy tool in a very near future. And also from the perspective of Olympus Corporation, which is the giant of this field, they are providing with the 4 items from the endo-brain format. And their main target is, I think, all categories of colonoscopy, including the computer-aided detection and the computer-aided diagnosis. When it comes to computer-aided detection, Endo-Brain Eye was released as a measure to help identify polyps, while they have 3 products such as the Endo-Brain, Endo-Brain Plus, and Endo-Brain UC, which provides us with the understanding on the characterization of the polyps or the inflammation status of the ulcerative colitis. And the society is also moving forward with the publication of the guideline. This is a blinded guideline published by the ESGE, or European Society of GI Endoscopy, where we can find a weak recommendation of the use of AI for colonoscopy. This is recommended because the use of AI is considered to contribute to improvement of the quality of endoscopy. So let me introduce the CDE first in more detail. So this is the how Endo-Brain Eye works during the endoscopy. As you can see, the reddish area was recognized as the area suspicious for the polyp. But actually, this was an invasive cancer rather than adenomas. So from this perspective, I think the CDE is really useful for both polyp detection and cancer recognition as well. I guess Dr. Misawa has a really big role in research and development this Endo-Brain Eye series. So his contribution is decent. I'm very looking forward to talking with him after this session, of course. So if you look at the evidence, there have been already 6 RCTs, and according to the meta-analysis, which assessed these 6 RCTs, the ADR, or the adenoma detection rate, was increased by roughly 50%, namely from 25% to 37%. This is a really decent increment, because this kind of increment can be expected to contribute to the improvement of the cancer prevention. But of course, there are some drawbacks in the field of CDE for colonoscopy. These are the breakdowns of some Chinese RCTs. And as you can see, the increment of the ADR was mostly attributed to the increment of tiny adenoma detections. So nobody knows whether this kind of increment really contribute to a reduction of colorectal cancer in the long run. Let us move on to the second topic, namely computer-aided diagnosis. This is a really important field because the use of CDX may reduce the cost of colonoscopy by reducing the amount of the unnecessary pulpectomy for hyperplastic polyps. So if you look at the evidence, there have been 6 papers published in scientific papers or journals in terms of the prospective fashion. But from the evidence perspective, I would say the level of evidence is less than the CDE field because there is no multicenter study, no RCT. Most studies just included the less than 100 patients. So I would say we should wait for a couple of years to be confident on the use of CDX from the scientific perspective. I'd like to pick up one study from this list because this study contains a large number of participants. This is the prospective trial to evaluate the value of AI in colonoscopy, especially in the field of CDX. As you can see, the polyp is predicted as either neoplastic or non-neoplastic in a real-time fashion. And this end-brain technology provided us with the over 90% accuracy in terms of identification of neoplastic change, which is a decent contribution, I guess. But of course, we have a lot of challenges forward. This is one example of our challenge. Let me introduce one case. This polyp is located at the sigmoid column. Actually, the histopathological examination showed that this lesion was invasive cancer with the submucosal invasion of over 3,000 micrometer. So this kind of appearance, I think, should be identified before doing endoscopic treatment or surgery. And this end-brain technology may help us identify the presence of invasive cancer in advance. So this end-brain plus allows us to predict the presence of invasive cancer in a real-time fashion, as you see here. And the important thing here is that the End-Brain Plus is already on the market with a regulatory clearance in Japan. So we are able to implement this technology into at least Japanese practice from today. And this is the performance of the End-Brain Plus. In terms of the differentiation of invasive cancer, it provides with the over 90% sensitivity plus 90% specificity. So this is amazing value, I guess, because we don't require any expertise to get this kind of higher sensitivity and specificities. And this kind of high performance is given by the really nice collaborative research led by Professor Kudo. And this is a multi-center study, including the Showa University, National Cancer Center, Tokyo, National Cancer Center, East Hospital, Shizuoka Cancer Center, Cancer Institute Hospital, and the Tokyo Medical Dental University. And this research was supported by AMED, which is a Japanese funding body. And we have collected over 70,000 images to produce this amazing technology. So I think the multi-center collaboration is mandatory to produce this kind of high-performance AI tool. So ladies and gentlemen, I'd like to summarize my talk from the AI perspective. I guess we have the full lineups of AI for colonoscopy, including the CDE and the CDX. And we have some guideline recommendation for the use of AI in colonoscopy, which is a decent value for us. And also, we may expect some possible cancer prevention effect from the use of especially CDE, because it will increase the adenoma detection rate. So I think it's a prime time to start using AI for colonoscopy. Why don't we try it? Thank you very much for your kind attention. I'm very happy to join any kinds of discussion. Thank you.
Thank you very much, Yuichi. Really fascinating talk, and very much enjoyed how the AI has been developing really over the last decade in particular, and your contribution to this field has been outstanding over the last 3 to 4 years in particular. So very much looking forward to having a good discussion with you in this session. So thank you for your time.
Dr. Amin, can I ask a question for Dr. Mori?
Sure. Please
so,
do.
Dr. Yuichi, thank you very much for your bright lecture. As you showed in your presentation, the current KD system only increases the diminutive polyps, which considered to be low-risk lesions. How can AI improve the detection rate of the large lesion? What should we do to the large lesions?
Thank you, Dr. Misar, for this kind of excellent question. Actually, these kind of things should be discussed thoroughly, because the reasons for why we miss a lesion consist of two components. One is the recognition error, and the other one is the exposure error. I think the decent number of the overlooked lesions or because of the lack of the mucosal exposure. So, but with the use of CADE, we cannot salvage this kind of lesion. So I think the combined use of the mucosal exposure device and the CADE would be the optimal option. So, so for example, you have the cap, or you have the endo cap. I think the combination of these kind of items together with the AI device would be the way to go.
Thank you so much. So mucosal inspection is very important point to detect the correct lesion. So I have one question, additional question about regarding the medical cost. So to my if my understanding is correct, I think the CADE increase the cost, such as polypectomy or pathology-related cost. And in contrast, accurate CADX maybe CADX will decrease such cost, allowing us to conduct a reject and discard or leave in situ policy. So my question is, when these CADE and CADX are integrated, will AI improve the cost effectiveness? So do you have any data or speculation about this issue?
Yeah, that's also a fantastic question, and we have already addressed that in our ongoing work with use of the microsimulation modeling. So this is a really very sensitive question, because apparently use of the CADE increases the cost decently, because as you mentioned, it will increase the number of the detected polyps, number of polypectomies, and even number of the surveillance colonoscopies because of the increased number of the detected adenomas. But this kind of thing will be balanced by the cancer prevention effect, or with use of the CADX, which can decrease the number of unnecessary polypectomies for hyperplastic polyps. So according to our preliminary analysis, if you follow up the patient for 10 or more years, I think the cost effectiveness can be recognized even under the use of CADE. However, if you observe the patient only for 1 or 2 years, I'd say CADE will be the evil in terms of economic variation. So we should have a very long-term vision when we evaluate the effectiveness or cost effectiveness of AI in colonoscopy. Thanks.
Thank you so much. So it's a very interesting point. I hope the cost effectiveness of AI will be established, and I hope the AI spread all over the world. Thank you.
So, Dr. Amin, so may I ask one question?
Please, Harry.
So I have a question to all of you. So now the AI diagnosis, computer-assisted diagnosis are getting better and better, we understand. So so far, in a regular endoscopic examination without using a computer-assisted, so we realize that the first step is a white light examination. Second step is a image-enhanced endoscopy. And this, of course, a combination with a magnification. Finally, endoscopy. Endoscopic examination that clarified really microscopic level examination, diagnosis, tissue characterization. So now you are using the endobrain first introduced to the field of endoscope, almost a microscopic diagnosis, and now your extended the application to regular endoscopic detection, and the further position of now in the era of AI. So the position of IEE, for example, NVI or something, and the position of a magnifying endoscopy in the field of AI. So Mori sensei.
Yuichi, do you want to comment on that, Yuichi?
Yeah, thanks, Professor Inoue. That's a really interesting point, because I think we do have too much options, including the optical biopsy modalities and the also computer-aided measures. But from my perspective, use of AI is going to be a standard in clinical practice, because some of the AI modalities have already been integrated into the proper endoscopy processors in Olympus, Fujifilm, or Pentax. So I think this is a way to go. And also, we should have some chance to reduce the number of this kind of modalities in the long run. However, currently, we don't have any knowledge which one is the best or which one is the worst. So I think we should do a lot of the clinical trials to identify the best options in our clinical practice in endoscopy. That's my perspective.
Thank you very much. Your comment. And the additional question is like that. So now, many AI endoscopy detection of the region, and then endoscopic image getting better, getting a high resolution image. So getting better and better. So is it really necessary to do a magnifying observation? So now we can get this very high quality, high resolution image. So if a computer assisted, so regular high resolution endoscopy image can identify the peak pattern. Is that right?
Professor Inoue, can I answer your question?
Yeah.
So it's a very important point. So as you mentioned, so recent Olympus X1 system allows us a very clear and detailed examination without any magnification. So in that situation, so AI have a potential to differentiate not only neoplastic and non-neoplastic, but also predicting the invasive depth of colorectal cancer. So, but more high resolution image is very effective for training the AI, I think.
So thank you very much. Thank you very much. And Dr. Amin Haji, may I ask one more question? Would you allow me?
Please do, Harry. Please do. But interesting, Harry, you were talking. I think it's an interesting point, because I continuously in Western practice get asked about magnification endoscopy, and will AI actually negate the need for magnification images? And obviously, we're all very biased towards magnification endoscopy in this forum because we enjoy and we have learnt magnification, and that's what's been brought up. But I think artificial intelligence will actually change some of that. Certainly for routine endoscopists, GI endoscopists that would be doing non-expert endoscopists that can use artificial intelligence in this manner to diagnose these lesions. And then if there is particular detail that's needed after that, that can be referred to an expert endoscopist who may use magnification to evaluate in depth. So I think that's a really, really important point. And I'm actually very interested in how this is going to develop. But thank you, Haru. Please go ahead. Your next question.
Yeah. Thank you so much. Yeah, I totally agree with Dr. Haji's comments. And the next question is simple, my personal interest. Do you have any case of a de novo cancer? I mean, a 2C lesion detected by CAD?
So it's a very important question. So actually, Dr. Yuichi showed a 2C-like lesion in his presentation. So end-brain eye can detect such lesion. And yesterday, so I saw in Japanese conference, so some doctor present a 2C lesion detected by the end-brain eye. So it's a very surprising for me. So maybe in the future, end-brain eye detects a lot of depressed type colorectal cancer. I hope so.
Wow, surprising! So congratulations.
Thank you.
Dr. Mori, may I one question? In the future, is there any possibility for AI to make a contribution to the field of endoscopic or surgical therapy, such as ESD or laparoscopy?
Oh, thank you, Dr. Kudo, for this exciting question. I think this is the future, I guess. Actually, we are working on some special computer-aided therapy during ESD procedure in Showa University. In this research, what we are working on is to identify the muscle layer during the procedure so that we can avoid a dissection of the muscle layer. So I think this kind of the support system for the very advanced endoscopic procedure will catch a lot of attention in the very near future. So I think the combined use of the therapy assisting modality and diagnosis assisting modality would be very promising, I guess. But of course, the assistance of the therapy contains a considerable risk in terms of the failure of the treatment. So I think we should be very, very careful when we develop this kind of high-risk device.
Oh, thank you very much. And okay, one more question. So I believe AI would be a very big advantage for many endoscopies. But on the other hand, there are some opinions that AI would prevent some endoscopists from improving their endoscopic skills, particularly for beginners or non-experts. Please let me know what your opinion is.
Yeah, thanks. This is exactly the point which was mentioned in the European guideline in 2019. This effect is regarded as de-skilling effect. And as you mentioned, this is a big disadvantage or possible disadvantage for especially non-experts. We should address that thoroughly. Otherwise, as you mentioned, the future is going to be very dark, let's say. So I think AI is not perfect, of course. We should understand the advantage and disadvantage of the use of AI and create a nice education method to maximize our clinical practice in combination with the AI.
Thank you very much.
But I think, Yuichi, what's interesting is we probably need to take a step back in terms of AI. We perhaps need some minimum standards to do the initial white light examination and sampling the mucosa, sampling a certain percentage of mucosa as a minimum standard to say, okay, this is a valid colonoscopy, and therefore, we can then go ahead and do adenoma detection rate based on that. What's your opinion based on, should we be introducing some minimum standards based with AI to say, look, okay, if you're going to do a non-expert endoscopist, if you don't achieve certain amount of mucosal sampling, then actually that's not a valid colonoscopy?
Yeah, that's a really important point. Actually, this kind of technology is an emerging research field called the computer-aided quality assurance. And in this field, the most eye-catching technology is the assessment procedure for the mucosal exposure during the endoscopy. So as you mentioned, the percentage of the mucosal exposure or the status of the bowel preparation can be assessed automatically with use of AI. And once you get a high score with this kind of quality assurance, then you can proceed to the next level, such as the polyp detection or characterization. So I think the combined use of computer-aided quality assurance, computer-aided detection, and computer-aided diagnosis, that will be the integrated medicine in the near future.
Thank you very much. It's a very, very fascinating discussion. I also have a question for Professor Kudo. Really fascinating talk. Really, I wanted to discuss and ask his opinion regarding endocytoscopy and actually endobrain. Do you think, Professor Kudo, that in the future we would be using this sort of technology worldwide in routinely assessment of diminutive polyps? And will we be moving to a strategy where we would support the discard strategy and using this technology to support that? So what's your opinion regarding that, and where do you think this field is going?
Yes, I think so. Endocytoscope can diagnose colorectal region with high accuracy regardless of size and macroscopic type. And endbrain also provides accurate diagnosis even for non-experts. So I think these devices allow us to conduct an endopathology that will omit formal pathological diagnosis. Thank you.
Thank you very much, Professor Kudo. That's very, very fascinating. I really enjoyed that session. And I would also like to take the opportunity now to thank all our speakers, Yuichi and Professor Kudo. It's been an absolutely outstanding session. And thank you to Masa and to Dr. Kudo and Professor Inoue for this fascinating discussion. I think, artificial intelligence is developing every day, and we have new technologies that are around the corner, and it's a very, very fascinating field. So I very much look forward to watching this space and seeing how this develops in the future. So it's my great honor now to close this session. Thank you very much for your time. And it's a great honor and congratulations to Professor Inoue for an outstanding Tokyo Live 2021.
Thank you so much.